Cardiovascular risk assessment in the middle-aged athlete. So 15 minutes, which is really about a 4-hour talk. But we'll see what we can do. Excuse me. Let's start with one quick question. What is the most common cause of sudden cardiac death in middle-aged athletes? There are your options: hypertrophic cardiomyopathy, atherosclerotic heart disease, ARVC, long QT syndrome, or dilated cardiomyopathy. So make your mental note and see if we can answer that as we go along. So our masters athletes, our mature athletes, our middle-aged athletes, we've actually had this debate recently about what to call them, some discussion about that, but they come all shapes and sizes, all different kinds of activities. Some look jacked, not Jack Salerno, but jacked from a different terminology. And a lot of them think, but not all of them, that they can sort of outrun the cardiac clock. But that's not the case. Some develop heart disease. Despite all this, some have events. Kind of the best case in point is our quintessential study in cardiovascular risk. So Jim Fixx, very famous, contributed to the evolution or revolution of running for fitness in the US, authored the complete book of running, ran 80 miles per week, died of an acute emia while running at the age of 52. So now we have to balance this sort of exercise paradox, and we can debate about what that exactly means, but Dr. Baggish clearly established the benefits of exercise, but there are also some risks. The question of these AFib, coronary calcium, and the risk of sudden cardiac death with exercise. In fact, when we look at this graph, the distribution by age of sports-related sudden deaths, that raw number is much higher in our middle-aged athletes than it is in our younger athletes. But then again, the etiologies start to switch as well, from predominantly inherited genetic cardiomyopathic or channelopathies to a much, much higher prevalence of coronary heart disease as the primary pathology. So we have to think about them a little bit differently, or a lot differently in some cases. There are guidelines, and I'll point you to the European Association of Cardiovascular Prevention and Rehab, or the American College of Sports Medicine, about pre-participation health screenings, particularly in the middle-aged athlete or the middle-aged person, not necessarily the athlete. Let's see if we can't put a general framework around these things. So I'm going to talk about 3 specific things to help us create a framework for risk assessment. One is their individual risk profile, their habitual levels of physical activity, and their intended level of physical activity. So let's start with the individual risk profile. And let's revisit Jim Fixx. His autopsy showed severe 3-vessel coronary heart disease. Prior to the age of 35, he weighed 240 pounds and smoked 2 packs per day. His father died of an MI at the age of 43. Multiple dietary indiscretions while he continued to devote a life to exercise, and multiple other non-traditional risk factors, including social stressors. So he was kind of the quintessential cardiovascular risk profile. Well, what do we know about sudden cardiac arrest during sports in this population? So this study looked at about 100 athletes, 60 athletes in this study, and a bunch of non-sports associated sudden cardiac death. And what they found is that risk factors still predominate. Diabetes is still there, but maybe not as high as we would think, but hyperlipidemia, hypertension, increased body mass, even overt obesity, and smoking are still major drivers in cardiac events. You've seen this graph from Dr. Baggish, so I won't belabor it too long, but you look at these subjects that had an event during follow-up. They had hypertension, untreated or treated. They had high lipids, in some cases very high lipids, quite a bit of smoking history, and they weren't exactly low risk walking around every day either, as their Framingham risk scores were elevated. So the calcium score debate, Dr. Baggish talked about this already. Calcium does not necessarily equal death, so correlation does not equal causation necessarily. Does it affect our outcomes? Does it affect the way we manage these patients? I don't know yet. So I would be careful using coronary artery calcium scoring to help you risk stratify your master's athlete, because I don't know what to do with that data yet. So all this boils down to risk. So this is the European score calculator, and the fact that it's the European score calculator or the Framingham risk score, that the theme is the same. So as you increase in age, as you develop or you have uncontrolled risk factors, including smoking, your risk goes up. That's whether you're exercising or not exercising. So it's important to look at those risk factors. Those can be modified by whether you have overt diabetes, whether you have a strong family history. All those things are going to play into your risk factor assessment and then your risk factor modification. So you need to aggressively control those risk factors. And that's really what we do for our patients, whether they're athletes or not. We risk stratify them based upon their traditional risk factors, and we control those risks, and we control them aggressively. But I said it's not all coronary disease. It's predominantly coronary disease. So if we look at the RACER study, which we've seen a couple times, about 10 to 11 million athletes over about 10 years, and we see other things also happen. So hypertrophic cardiomyopathy and coronary disease are not mutually exclusive. So other things can be there. So don't ignore other symptoms and say, well, your blood pressure's fine. There are other things you need to be on the lookout for. Next piece of that framework, what's their habitual level of physical activity? Well, this is important because exercise does certain things, right? Acutely, it increases our sympathetic activity, increases catecholamines, immediate post-exercise. We have arterial vasodilatation. All these things can perturb the system to decrease coronary perfusion, increase ischemia, and increase myocardial irritability. So this factors into this graph. So this is the risk of an MI as it relates to your habitual level of physical activity. So as we perturb the system that's not used to being perturbed, our risk goes up. We know that without exercise, your baseline risk is higher. The more you exercise, the lower your baseline risk. But no matter what you do, your risk of an event during exercise goes up. The higher your level of habitual activity, the less it goes up, so that those people who don't exercise have potentially 100 times greater risk of going out and playing weekend warrior when they're not used to it versus someone who exercises regularly or on a regular basis. What about their intended level of physical activity, and how does that play a role? Well, that boils down a lot to exercise intensity, and we know that the positive benefits are largely associated with moderate intensity activity, but the potentially negative effects are predominantly related to high intensity, and this refers to, quote, strenuous exercise, often referred to as greater than 6 mEs, but really we're talking about things that happen above someone's ventilatory or lactate threshold. We can use this very famous picture, the Mitchell classification, to help us define maybe what kind of activity they're getting into, whether it's more high intensity, so the farther you move across to the right in terms of aerobic activity, or higher dynamic component. We can use relative risks, or relative levels of exertion. So that ventilatory threshold for most people around 50 to 60% of their VO2 max. The more fit you are, though, the higher it goes up in relation to your VO2 max. So that these levels of percent heart rate, relative perceived exertion, or percent of your VO2 max, which are all determined a little bit more empirically perhaps, may be more useful and helpful to know where they stand. And this factors back into our last discussion, their level of fitness. So someone who's quite well fit, their ventilatory threshold, their lactate threshold is going to be higher relative to their VO2 max. So if two people are operating at about 70% of their VO2 max, someone may be at or below their ventilatory threshold or their lactate threshold, which may be an important factor, so that us doing the exact same exercise may be a lot harder for me than it is for you. So my intensity is a lot higher than it is for someone who's super fit. And why is this important? Why is that strenuous exercise then important when we talk about risk? Increased risk of catecholamines probably being the biggest driver. So this study looked at rowers. So on the x-axis is increasing their 500-meter pace. So they're fasting, pulling harder and moving faster. And we look at where their lactate level starts to rise. And then we look at where their norepinephrine and epinephrine level tends to rise, and it tends to be after their lactate threshold. After their lactate threshold. So that increased risk of catecholamine surge, we think, has a lot of potential risks, especially in someone who's not used to living up there. Could also increase their platelet adhesion and activation, increased risk of thrombosis. Most people's ischemic threshold are above that lactate threshold. an increased risk of complications. So how do we then evaluate all these things? Further potential testing, right? We always talk about more testing. We're going to talk specifically about EKGs and stress testing. What do we know about screening asymptomatic adults with resting ECGs and electrocardiograms? So this USPTF evaluation looked at the accuracy of resting or exercise ECG for risk stratifying patients into high, intermediate, and low risk. And what they found that in the general population, no study examined or estimated how accurately resting or exercise ECG plus traditional risk factor assessment reclassified patients based upon traditional risk factor assessment alone. But they did say that pooled analysis showed that abnormalities on resting or exercise ECG shows an increased risk. How that relates to your other traditional risks wasn't so clear. So in general, screening ECGs and screening exercise stress testing in the general population is not recommended yet. Plus, we know that since we're talking about the international criteria and whether that applies, well, I'm not sure it really applies to the masters athlete population. All the data was developed from young athletes, not from masters athletes. So I don't know if you can really use that same criteria in a masters athlete population. There are certainly things that aren't normal, but when we get into those yellow zones, I'm not sure that we can really use those. In general, though, ECGs have a low sensitivity for coronary artery disease, so if that's the most common cause, how can we really use that? Well, there are some data, very limited data. This study looked at about 100 athletes that had comprehensive screenings. And what they found was that the ECG did find a few things that they wouldn't have suspected otherwise. Now, it wasn't always coronary disease. They did find Wolff-Parkinson-White, hypertrophic cardiomyopathy, which I said can exist in the masters athlete, that may affect their participation or their risk of participation. But they also found things like we would expect, risk factors, uncontrolled hypertension, hyperlipidemia, diabetes. So you may be able to gain some rational use of the ECG. What about exercise stress testing? Again, the caveats, and I said this yesterday, this is not 85% of your age predictable maximal heart rate and stop. These are maximal volitional fatigue stress tests. I tell them 5 seconds shy of flying off the back of the treadmill. That's when we're going to stop. And you need to reproduce their physiology, whether that's endurance sport, sprinting sport, interval sport, running, cycling, rowing. You need to try to reproduce their sport as much as possible. So what are we looking for with stress tests then, right? So what causes these events in endurance athletes? This study looked at cases from the Boston Marathon from Paul Thompson in the New England Journal of Medicine, and they showed that they thought it was acute coronary thrombosis, so rupturing of a soft plaque that caused the acute coronary syndromes. In fact, we sort of know that anyway from this meta-analysis from Falk, showing that nearly 2/3 of all acute coronary syndromes are from lesions that were less than 50% immediately prior to their event, but not all. This is in contrast, though, to the RACER study. Again, that same study we've looked at multiple times. And if we pull out the causes of sudden cardiac arrest and specifically focus on this group right here, it says myocardial ischemia. Notice it doesn't say myocardial infarction, it doesn't say coronary thrombosis. And when we looked at the autopsies, they had fixed obstructive disease. So results from this study suggest, well, maybe it's not all acute coronary thrombosis, that maybe there is some fixed disease and we have outstripped the myocardial oxygen demand for too long, leading to catastrophic events. In which case, stress testing may play a role. Stress testing looks for fixed coronary disease. So let's put this all back together. And I think using this same habitual level of physical activity and relative risk of MI is a good way to put this framework all together. So the first thing we talk about, again, is risk factor profile and risk factor modification. That really sets our baseline risk. What are we going to do for any patient, whether they're an athlete or not? And how can we lower their baseline risk, which they may then lower their acute risk? What's their level of habitual physical activity, particularly those ones that don't exercise too much that really want to start exercising more? We know their risk is higher. And how can we modify those and counsel those, which is certainly part of the equation? And what's their intended level of physical activity? This tends to be the exercisers who are already doing something that want to do more. And then how can we put that all together? That's when we start to put the whole framework together and we start thinking about, well, Is the ECG going to be useful in this situation? Is the stress testing going to be useful in this situation? And how are we going to use that in our big profile? It all starts, though, with that risk factor and risk profile modification. So, blank slide won't be shortly. Very famous quote that I'm going to credit to Aaron Baggish in the recent Washington Post, but he's said it multiple times before. But direct quote, "No amount of exercise confers complete immunity to heart disease. You can't outrun heart problems completely." What that boils down to is exercise does not equal immunity. That's part of your risk factor and risk profile and your discussion with your master's athlete. No matter what we do, your risk is still going to be elevated. You need to pay attention to that. Pay attention to these symptoms. Pay attention to all the other pieces. General suggestions, we'll breeze through these because they're basically what he said. Make sure you prioritize the warm-ups. Be aware of unusual symptoms. Don't exercise through that viral syndrome. Adequate hydration. Make sure you know the environment you're going to do and how good a shape you're already in. Thank you.